Okay, well, good morning, everybody, and welcome to our virtual grand rounds. This will be the last for the summer of this series, and so we'll recess with the exception of at least one faculty meeting in this time period until September. And on September 2nd, one of our own faculty, Guillermo Jorga, will give grand rounds, and he has some fascinating data, so that'll be a great way to start off the academic year. I just wanted to mention a couple of announcements. One is that Tamara Sussman received a 5-year KO8 from NIDA for a project to study longitudinal study of Puerto Rican children and the impact of adverse childhood experiences on cognitive control and risk for substance use disorders. And Adam Basaga received a 5-year UO1 from NIDA on efficacy of buprenorphine and extended release naltrexone for relapse prevention and opiate use disorder. Also, Warren Eng was honored again with another thing. He was selected president of ADPERT, not ADPERT, the Child Psychiatry Association, and he was just appointed to the New York State Behavioral Health Services Advisory Council by Governor Cuomo. And similarly, another honor was Ruth McCann, one of our PGY4s, Joe Villerin. PGY4 received the Samuel Perry Distinguished Award in Psychiatry, which is given in honor of Sam Perry by Weill Cornell School of Medicine. Let me just brag a little bit, particularly with one of our Harvard colleagues as our speaker. Not that we pay much attention to it, but the US News and World Report rankings just came out, and the hospital is glowing because it moved up to number 4. So the top ranked hospital in the country is Mayo Clinic, then Cleveland Clinic, then Johns Hopkins, and then in a tie for 4 is New York Presbyterian and UCLA. Jonathan, I'm sorry to say, but MGH dropped to 6. I don't know why that is, but in any rate, it's a beauty contest, so I wouldn't attach much importance to it, even though the hospitals live and die by it. Just to say a word about COVID and the current situation. So as people know, we've been immersed in this now since March. And the good news is that New York, the governor, our institutional leadership is managing it very carefully and effectively. And the decline in infection rate is continuing, but it's not eradicated. It's still present in terms of number of beds in the hospital occupied by COVID people, number of new infections, and also number of deaths, but it's really one of the lowest in the nation. And we've begun a reactivation process, which is being done in stages, and we want to sustain that, but it's going to be something where we're taking one step forward and then determining if we can take a second step forward or if we have to take one step back. And so the mantras that we're advocating and following are: we need to be COVID safe for ourselves, for our patients. Our commitment in terms of department leadership is that we have your back. And the safety plan, which is put in place under the leadership of Rosella Taraborelli and Evelyn Attia and Rebecca Owens and Lisa Corneau, is that we're trying to attend to the safe means of transportation, screening, social distancing, PPE, including masks at all times, disinfectant, staggered work schedule, telemedicine, testing, monitoring, and tracing. Now, all of these things have different levels of difficulty in achieving, but those are the elements in achieving optimal COVID safety, which we're focused on. We will have a faculty meeting sometime in August to review the COVID situation as well as other items in terms of updating you. But so far, so good for now, but we need to keep on doing this. Well, I don't think we could have timed a more appropriate topic for this grand rounds and speaker, who is really one of the leading people, even at his youthful age, in this area, which has to do with the application of virtual means of medicine and health and digital technology to healthcare, and that's Dr. Jonathan Torous. So Jonathan, I'm assuming, hails from California because he went to undergraduate school at Berkeley, and then he got his medical degree at UC San Diego. He also received a degree in biomedical informatics, then at Harvard, And he remained east to complete his residency and fellowship in clinical informatics and medical education before remaining on faculty at Harvard. And going through a CV, I felt that the most notable things that I could point out, as opposed to the usual things like grants, publications, and so forth, was the fact that he is really in the vanguard of forging tools and policies for the use of virtual and digital technologies in healthcare, and specifically mental health care. And towards that end, I just wanted to read a couple of the things that he's achieved in this regard. You know, everybody talks the talk, but not everybody walks the walk. And in this case, Jonathan has certainly done the latter. So in 2014, he developed an Apple and Android smartphone app to assess PHQ-9 symptoms of depression, including suicidality. He also created the first clinical guidance for evaluation of mental health smartphone apps to be endorsed by the American Psychiatric Association. He created the LAMP. What's the acronym LAMP start for, Jonathan?
Learn, Assess, Manage, Prevent.
The LAMP smartphone platform, composed of Apple and Android smartphone apps and a custom API and custom database to enable digital clinical care and research. He also created and planned a new wiki for psychiatry residency programs to replace the internal websites. He also developed a method for, the terminology of digital phenotyping. So this has become, I think, one of the new commonplace terms, if it's not already, soon to be added to Webster's dictionary. But with Dr. Onella at Harvard School of Public Health, he was author of the paper that defined the term digital phenotyping. He created the first digital mental health clinic that used smartphone technology to augment and extend outpatient care, and created a new digital health literacy program for patients with serious mental illness called DOORS, Digital Opportunities for Outcomes in Recovery Services. And it's a 4 to 6 week course with an accompanying training manual. So the timing of having him speak with us today couldn't be more appropriate. So it's my pleasure to introduce Dr. Jonathan Torous.
Thank you, Dr. Lieberman, for inviting me, and thank you guys for tuning in. I'm going to see if I can get this screen share to work and you can see the slides. We'll have a technology adventure. Let's see. I'm going to go share. Need to go. No, not quite. Let's try that again. And let's go to home. Go to slideshow, current slide. Okay. I need to just switch it around. Let's see. Can you guys see, which screen do you guys see?
We're able to see your first slide, Beyond Telehealth.
Okay. And you don't see the slides on the bottom, the preview?
Nope.
Okay, so we're perfect. So again, thank you for inviting me, Dr. Lieberman. And it would certainly be a lot more fun to visit and talk to everyone in person, but I think this is a talk that we can definitely do very well virtually. So as Dr. Lieberman said, I'm at BIGMC, so up in Boston. And what we're going to talk today is a lot of different things, and hopefully by the end of this talk, these will make sense. So we'll talk about kind of why we built a smartphone app. We'll talk about kind of why we built a database of mental health apps, why we built different types of training for clinicians and patients, and how those pieces kind of come together into different efforts. And I think you'll see that the goal is not to say it's all data science, it's not all clinical work, it's not all design. It really is looking at how these pieces come together. So I think no matter what your background is, there's something I think that you can contribute that's interesting and important in this evolving digital mental health space. And so my favorite cartoon, or several, but there's Maslow's hierarchy of needs. And I think anyone who's kept a patient waiting at some point has realized that Wi-Fi and battery are kind of part of that now. And it's certainly becoming more and more part of life. I won't go into different stories about how this happens on our inpatient unit and what happens when you take away people's smartphones. But to really give a talk, what we're going to talk about is basically smartphones and mental health. What are the broad potentials? We'll talk about this term digital phenotyping, what it means, what we can do, and then talk about app evaluation. When the patient brings you a smartphone app, when you're interested in them, how do you kind of make a good clinical decision about picking one of these? And I think the cartoon on the right from the New Yorker really summarizes this field well. It really is nascent. It's just being born. All of this is new and interesting. So if there's something on any slide that you disagree with, you think there should be more done, the answer is you are right. There's so much to kind of explore and it's new. So whether, again, you're a medical student, you're a trainee or resident, a fellow attending, there's so much you can kind of do in this field, and there's so many kind of important initiatives to be undertaken. So with that caveat, I'll kind of jump in about what do we know about, like, why focus on smartphones? I won't focus on telehealth as much because there's a much broader literature on how telehealth works. We've all had to learn how to use telehealth, regardless of what we think of it in the last couple months. But looking at kind of smartphone ownership between 2017, the best data from Pew is 2019 I could find. You could see that kind of smartphone ownership went from, can you guys see my mouse?
Yes, we can.
You can see it was 35% around 2011, and it really shot up to like 77%. And you can see it kind of has remained roughly, it hasn't increased too much in the last 2 years. It's kind of saturating about at 81%. I'm sure it's probably 83, 84%, but you get an idea of it really came out of nowhere and kind of jumped up very, very quickly.
Now, Jonathan, is that smartphone as opposed to simply a mobile phone?
Exactly. So this is literally, so this would be a smartphone, these iPhones, these Androids. And this graph on top for the 2019, that's kind of any kind of phone up there. So clearly there is more prevalence for kind of any type of phone, but really smartphone is really getting up there. So you see here, cell phone is still more common, and but smartphones are rising pretty well. And I won't go into details. We've done a lot of research on our patients with psychosis in Boston, and they have, at least in urban areas, pretty high rates of smartphone ownership, as do most people. Of course, you want to look at the who's not connected, who are we still missing? Technology can reach more people, but not everyone. And this was a little bit over a year old data, but also pretty good at looking at what people are offline. You can see here that the percent of people offline is decreasing. This is a good trend, but we're not reaching everyone. It is older people, it's minority populations, it is people of less income, it's people with less than a high school education, it's more rural. So I think we can have hope on this left graph that we're connecting more people, reaching them with these kind of digital, mobile, online tools. But we do have to recognize that our most vulnerable patients still may not be connected. That said, they may be, and again, I think we'll see this 10% hopefully continue to go down. So, but just because we're talking about smartphones, it's worth keeping in mind that we're not quite reaching everyone, but we're doing a good job in getting better. There's a lot of things you can do in this field of kind of digital mental health, digital psychiatry, whatever you want to call it, from mobile devices to tablets, again, to traditional telehealth, to VR, to games, to smart homes. It's pretty vast and wild. And I think each of us could probably find a whole career in any one of these buckets. I'm going to focus more on smartphones today. Again, really not on telehealth, but each of these buckets is a pretty exciting area that has a lot of new advances coming. And it's just for the sake of time, there's only so much that we can cover. So as Dr. Lieberman said in the introduction, one of the first projects that our team kind of did in this space, actually when I was a resident, was we built a simple app. And these are 3 of the 9 questions of PHQ-9, but it would give you 9. And we basically looked at what do people's PHQ-9 scores look like over 30 days. So the green boxes here and here are kind of in-person PHQ-9, and this blue thing that kind of jumps around, that's the daily PHQ-9, where I kind of smoothed it out. And these diamonds are when there were thoughts of suicide. So you can see for this one patient, there's a lot more reports of suicide to the app. There's a lot higher severity. There's a lot of variance. And in person, there's no diamond here. Even though the PHQ-9 looks back 2 weeks at this bar, this person was saying, I had no thoughts of suicide in the last 2 weeks, but to the app, there were 4. You can see, even by just asking people active data, and I call active data because you have to engage, or you have to take the survey, you really get a lot of data, and this actually can already cause some clinical workflow issues. How do you respond to those suicide warnings? Right now, the standard of care is to put up an alert that says we're not responding to them, just like it's a diary. But you can see from something fairly simple, a lot of interesting clinical, ethical questions emerge right off the bat. And you can, of course, do a lot more than this active data. Passive data is kind of termed because it gets collected regardless of what you do. You don't have to actively engage. And we all know that these smartphones, and that's why we'll kind of focus on smartphones, have a lot of sensors on them. And with a lot of these sensors, some of them may be proxies for behavior that may be of interest to us in the mental health field. And some of them may not be of interest. And the key word is proxies. Like any kind of sensor, it's not going to be a one-for-one. But you can imagine there's a lot of research looking at how microphone data can capture voice, and can voice inform us about kind of depression risk, about depression etiology, about different subtypes of depression. So can we learn a lot from that? You can imagine there's a lot of work on using cameras to get facial expression for people and learn about real-time affect. So some of these sensors it gets into are not available anymore. This was the figure I made in 2017. Getting call and text logs has actually not been allowed on iPhones for a long time. Android is moving to block that as well. So before I wouldn't know who you called, but I know that John made 10 outgoing calls and got 3 incoming calls. I'll show you the detail. So this is also an evolving thing of what data that you can get. But I think active and passive data can be put together in very interesting ways. For some of our ongoing research, you can see on this graph, we are kind of asking people stories about anxiety, mood, psychosis, sleep, and step count. And we noticed there was a very big change when kind of social distancing was instituted. And again, we didn't have to ask anyone. It's just you notice these trends because everyone has their smartphone, they're partaking in the survey, and you really can detect these trends. Right now, we're doing a study of college students during COVID because it's easy to consent college students online. They have smartphones. And you can see that we are tracking some things like sleep and screen time, as well as something like self-reported alcohol use. And when you combine active and passive data, you can get a lot of information about students. And oops, wrong button. And again, we'll go into kind of what some of this data means, but you can really kind of reach people and do some interesting research, especially in this era of social distancing now, through phones and combining both active and passive data. They don't have to be either or. There's also interventions, right? These phones can do more than just collect surveys or sensors. People always ask me, what apps do you recommend, John, or like? The VA makes a wonderful suite of apps. We'll talk about why it's a great suite of apps. This is a new insomnia coach app they released about 2 weeks ago. And on the right is actually an app that's for psychosis and schizophrenia. And this app, again, this is a 2014 paper when it started, but it recently actually got kind of quasi-FDA approval as an app for schizophrenia. And it kind of, everything's a little bit stranger to FDA during this public health emergency. But basically, there is an FDA-approved app where it's kind of gone through FDA kind of procedures for psychosis. So interventions aren't kind of these wild things anymore. Again, the VA has ones, but there's also a couple apps that have got FDA approval for the substance abuse space as well. So when you put together active and passive data and kind of these app interventions, things you can deliver through the app, it really does become a very powerful tool for the field. And in part to do research in the field and not kind of have to worry about who owns the data, ethical issues, licensing fees, we ended up building our own smartphone app tool. We now have funding from the Wellcome Trust to keep it free and open. But the basic principle here you can see is we, of course, can get symptoms through active data, but you really want to learn about activity. And that could be, again, through step count on the phone. It could be through wearables. You want to learn about timestamps. You want to learn about kind of people's green space exposure to environment, and really think of mental health in this new holistic way, right? It's symptoms and the patient are still at the center, but you can really now begin to kind of understand a lot of the context that we really haven't brought into clinical visits, clinical decision making, because it was so hard to ask people. We could kind of say like, what was your sleep environment really like? Like how much ambient light were you exposed to? How much were you exercising? So I think these are things we've always wanted to do as a field. And now the technology can allow us to do it. So this kind of brings in this idea of digital phenotyping. And
John, before you get into that, what are timestamps?
so timestamps really are just kind of when people did every activity. So when did they take a survey and how long did they spend? We'll go into like how long did they spend taking the PHQ-9 question 9? Did they actually answer the first 8 questions about depression, no sweat, and then they spent 5 minutes pondering, am I suicidal or not? So even something as simple as knowing how they took it and recording it can be valuable. So it kind of leads us into what is this digital phenotyping? And to be more NIH's, take an RDoc view to research domain, you can kind of say that digital phenotyping says we can learn about behavior, self-reports, and maybe physiology. We can't really get heart rate variability very well, but we can kind of then hopefully match these up to these kind of interesting biological research targets, right? So if we're doing great neuroimaging research and we're trying to say, does this kind of correlate to patients with negative symptoms of schizophrenia? Maybe instead of assessing them just on the PANS, we look at are there kind of evidence of negative symptoms in behavior and self-report? Can we get a real-time picture? And in some ways, this is the same picture, right? The smartphone can collect all these types of data. We can get these composite digital biomarkers for disease states and think about are these kind of new ways to match up our biological research and insights. And of course, we can use all these things today in care to some extent well. So one question is, well, how the heck do you turn the smartphone information into anything clinically useful? So these are 2 patients on the left and right. And on the left, kind of, you can see days 1 through 105, and here you can see days 0 through 92. And red is kind of activity, and white is lack of activity. And you can see for one day, lots of activity, no activity, activity. So you can kind of get an idea when sleep is happening by lack of activity. And for this person, you go, what the heck? There's no data from like day 32 to 42. What happened? Was there an alien abduction? Did they delete the app? Did it stop working? And the question is, we don't know. Sometimes when people are using smartphones to collect data, again, these aren't medical grade devices. The operating system on the phone can turn the app off. This is usually more of the case of sometimes we just don't get data in. Just like when you ask a patient to sometimes fill out a sleep log or a DBT diary card, you don't get data back. This is more the common case of kind of what happened here. And usually it's a technical issue. And again, you can see this data is noisier. It's harder to infer sleep. And was the person waking up here? Was it just noise? If this is all based on accelerometer and the phone was moving, did they have the phone on the bed? Did they have a bed partner? So the bed was moving. But so the idea is we can probably learn about macro sleep patterns. It's going to be a little bit hard on a day-to-day basis, and we're going to be really honest to get sleep perfectly. But you can imagine on a week basis, we're getting a pretty good view of what sleep is. And here's kind of what the passive data can look like in a way. So you can see there's surveys up there 3 times a week, and it looks like the person missed a survey. And we can get GPS, and we can quickly turn GPS into metrics like circadian routine, GPS amount of time recorded. Here's home time we can try to infer. You can say, oh, it's interesting. There's more home time on these 2 days and these 2 days and these 2 days. This must be Saturday, Sunday, right? So you can almost begin to make some inferences just by looking at kind of these passive data metrics. Again, we used to be able to get more information on call and text logs, and it's harder to get this. One problem is a lot of our patients, we do research in early psychosis, had no call and text logs. And we said, well, is this evidence of negative symptoms? Are people not kind of social? And they said, no, John, you're just not hip and you don't use Facebook Messenger. We do all our contacting through Facebook Messenger, and who would ever send a text message or make a phone call? You have to kind of realize how we're using technology. So again, every sensor you kind of see here or we use, it's a proxy. And for some people, of course, like they're going to make lots of phone calls. This will be a good metric of kind of their social engagement. For some people, it's not going to be the right metric, but it gives you an idea of what the passive data can look like underneath the hood. Here's a completely different person. You can say, wow, there wasn't GPS for these days. Is it because they turned off the GPS sensors, because the app stopped working? Then we got more data. So again, you can see that it can be pretty messy data, but we can collect it. And it's an evolving ecosystem of what Apple and Android will let us collect each year. They kind of update for good reason, kind of what we can and can't do. I can talk offline. We just released a new version of our app and went through a pretty extensive review process with Apple. And in a good way, they're becoming very tight on what they kind of approve and what data that you can get. Kind of as what Dr. Lieberman said about these timestamps, one interesting feature of timestamps is we can have people play mini cognitive tests. And you can kind of see when people take a kind of mini cognitive test on the phone, this is kind of like a trails test. You can see kind of a spatial span test here. Because we get a timestamp of when you touch the screen in the app, and only when you're using our app, we don't know what you're doing outside the app, we can kind of recreate how you took the test, if that makes sense. So it's not just your score, your accuracy, it's where did you make a mistake? How quickly did you error correct? Did you give up? Did you keep going? Did you get faster? What was your learning rate? So there's very interesting metadata that we can pull from this. We can have people do different drawing tasks and see how they did. So it's more than just the sensors as well. And to kind of give you guys I'll call it the greatest hits of what we can do with some of the data, what I kind of am exploring in my K23 award was our pilot data. We showed that this is for one person. We can learn about relapse in schizophrenia. This is when a patient, again, one patient got relapse on this date. And what we did is we took these 3 metrics from the smartphone, mobility metrics, which you guys have seen what they are, sociability metrics, you saw what they are, and kind of self-reported clinical outcomes, so a fancy word for surveys. And for the first week, we kind of had a baseline where we said, we don't know how many steps you take. We don't know kind of what you look like being social on the phone, but we said, let's get a baseline for that person, and then let's set a threshold. What would be kind of a deviation or anomaly for that much? And we said, let's then see each day, kind of almost like in a GWAS, are they above their personal threshold? And this day, something was very different about this person's survey responses, but that was just nothing. On this day, these 2 days, there were 2 days of survey responses that were above the threshold, and or sociability differences above the threshold, and mobility. So we kind of said when we kind of see multiple data streams having statistical anomalies at the same time, that seemed to be correlated with risk of relapse. And again, this is one patient, but we noticed this pattern over and over again. And we've been exploring this for the last several years in my K ward, and it seems like we are able to get an early warning sign. It's not that any one data stream is better. It's not that any one combination of data streams is better, but it seems that for patients, there's unique combinations of data streams that kind of, we'll say, go offline or kind of deviate together. And it's not perfect, but I think we're getting closer to kind of having at least some early warning sign of some type of kind of relapse risk in schizophrenia. So one thing we learned in doing this research is we're collecting a lot of data from patients, and they said, John, we keep giving you all this data, and that's great. We know you're doing important work of it, but can you give us something back? So we kind of took a lot of our work and said, well, let's put more into it than just trying to prevent the P. And my mentor in this work is Michiri Keshavan, who some of you may know at Beth Israel. And Michiri Keshavan said, of course we have to do this. And we came up with a new name, and I'll give him credit for most all of the success in my career, but also for naming LAMP of Learn, Assess, Manage, Prevent. So what we did of LAMP is we can now kind of give people health news and health tips customized to them. We can assess them, and this is kind of the digital phenotype you guys have seen of environmental, tagging, geolocation, calls, texts, surveys, step count. We can also begin to offer people management things, and I'll show you we're beginning to build these out. In-app exercises, medication reminders, journaling, basic mindfulness, and then a dashboard to look at your results, talk to the care team. So LAMP has kind of progressed from just kind of trying to capture this passive data in surveys to something that's a little bit more engaging and kind of gets people, it kind of is a better way. And we've done a lot of co-design on LAMP. We've had a lot of focus groups. It's been a lot of fun to kind of co-build something with very diverse people in building it. So new LAMP kind of looks like this. There's kind of tips you can go into. There's a feed, there's surveys, but there's also management activities. The hospital doesn't want us messaging people in the app because that creates liability until we figure it out. But technically, we can send people messages. We can kind of look at data. So it's really design becomes very important in this work and kind of building user interfaces and tools that are easy for everyone to engage with, even people with cognitive deficits is very important. And what we've done, we've taken this approach towards LAMP where, again, now we're lucky to have welcome trust support as well as private donors, but we've really kind of given it out for free. There's no intellectual property, it's open source code. And different groups around the world, from Monash University in Australia to Oxford in the UK to groups in India, are kind of using it, customizing it to kind of meet their own clinical study needs. And so we've built kind of what we call LAMP Consortium. We kind of have monthly webinars. We kind of talk to other sites and see what they're doing and studying with it. But it's been kind of exciting to have a tool that other places can kind of pick up and use. And again, I'll say there's certainly business cases, but I don't think selling an app in mental health is a business case. I think if people want to be entrepreneurs, there's probably better places than mental health apps per se. So our approach has been giving everything away for it. So you can kind of find out more about that online of how we've done it. But different cases that we've done and other people have done is you can definitely look at this data longitudinally, just show patients their symptom trends. This was a case where showing that someone kind of had improved sleep, their psychosis, anxiety, depression symptoms went down. As Dr. Lieberman pointed out, this was a small study where we could look at how people took the PHQ-9 and look, it's interesting, even though this person would kind of indicate a lower response for the suicide question, they may have spent more time. So we kind of looked at trends overall, and can we learn about suicide risk, not just based on what you say on the survey, but kind of how you take the survey. And again, that can be interesting. As we talk about the cognitive data, there's a lot of, I put cognitive in quotes because it's not really validated. We're doing more research on it. We have some studies, but when you look at kind of these traditional cognitive measures, but you can now understand the process of how someone took it, there may be new insights to be gained into kind of how people are thinking. Are there kind of early cognitive markers that we can learn about remotely? And as I showed you guys how we're doing our risk prediction, we can now kind of scale it up and look at risk prediction in multiple patients automatically with our kind of new pipelines. And it's, again, we seem to be getting good results. We have papers that are kind of somewhere in the peer review process, and one day we'll hear back about them. But we're excited that there's some potential to kind of customizing risk prediction to people based on what data they want to share and what kind of is their unique digital signature that may indicate some type of risk. I think you can also begin to look at very interesting kind of population studies. I think most of us learned in medical school and residency that for risk factors for psychosis and schizophrenia, traditionally, at least I was taught that urbanicity is a risk factor and being a rural is protective. And this isn't my work, but again, interesting papers kind of saying, you know, when you look at low and middle income countries, that urban-rural divide doesn't hold. It's a little bit more complex. We really need to look at the environment better to understand what's happening with our patients. And with smartphones, and again, the right permissions, we can look at that. This is a map of the environmental justice area of Boston. Environmental justice area is how each state takes census data and kind of marks out areas of maybe lower income, less kind of community resources, more poverty. But it's kind of areas that are maybe not doing as well. And what's interesting though is we can then look at where, as an aggregate, is our population of people spending their time? Are our patients spending more time in environmental justice areas over the course of our study? So it's not just where their zip code is, where they're registered, where their insurance billing address is. It's really what is the environmental exposure of our patients in different neighborhoods. And there's actually an index called NDVI. It's actually a green space metric that is usually each state has a very good index of it. And in this case, a high NDVI is kind of more green space, low is less green space, more like a parking lot, or kind of like, I suppose like downtown Manhattan would probably have a very low NDVI. But what we could do then is look at our patients with schizophrenia and kind of say, well, our patients who overall have had more exposure to green space, so high, again, we saw these correlations that they tend to have lower symptom burden. Of course, correlation is not causation, but you can begin to say we can answer these very interesting questions or begin to kind of tackle them in new and exciting ways that you really couldn't do before, and looking at how the environment impacts our patients' mental health. And of course, this really brings up the question, can smartphones be a proxy for symptoms? If we're collecting, again, all these types of kind of passive data that I showed you, and all these types of kind of active data, do they correlate? When do we need each? And I think this is really an active area of research. No one really has the full answer to it. And in some of our research we've done, it really gets complex. This is a paper we just put out, and again, it was in psychosis and NPJ schizophrenia. And what we found was, again, it was actually routines of all our passive data metrics. It was really taking a GPS metric and looking at kind of, are you kind of following a stable routine or not? That seemed to kind of have strong correlations or kind of people with more symptom burden. I think clinically that makes sense. We know that our patients that maybe don't have stable housing, that don't have kind of stable employment, sometimes they're not doing as well as those patients. So again, I think we can begin to learn about that, but there's a lot of kind of interesting correlations to look at. There's also room to get yourself into a lot of trouble by not controlling for multiple comparisons. So, and again, this is a schizophrenia study. What this would look like in depression, anxiety, and eating disorders in adolescents. There's a lot of interesting things to do. Our favorite way of interpreting the data is just to bring it to our patients and ask for their help. We become very humble in this, and we kind of can make correlation matrices and say, hey, when we think you have better sleep on the phone, does that mean you kind of have lower burden of psychosis and depression, anxiety? Does that make sense? So we do a lot of work in talking directly to our patients, and they usually help us interpret. They go, John, that makes no sense, or that data doesn't reflect me, and sometimes we're right, sometimes we're not, but it really helps us course correct very quickly. One thing that we're excited about, but still working on, is if we do have this longitudinal data on patients, we kind of have months of survey data, can we begin to kind of build networks for each patient, understand kind of how do symptoms evolve? So if this person is having really high anxiety, where do we think kind of their next state is going to be? Or what's kind of the greatest risk? In this case, maybe this is our population, mood will be the most elevated for this person. So can we kind of build individual symptom networks for patients? And this is early work, but you can imagine that if we can build individual symptom networks for patients, we can begin to think about prevention, or say, what are we kind of looking for next? What are we most concerned about? And of course, we want to kind of treat all symptoms at once. But sometimes we can kind of say, hey, we know you're really anxious, but we really need to be talking about mood as well now, because that could come next. So again, this is very early work, but I think it just shows you the potential of where all this could go. Putting it all together, again, I kind of show you these little pieces of what we can do and what we are doing. We have a project in India and Boston where we're going to kind of look at passive data and active data, get these digital phenotypes, do this kind of anomaly detection I showed you, and then kind of match it up to what could be the right kind of smartphone interventions to push to people. So this would be kind of idea of a just-in-time adaptive intervention. So you can see all the pieces kind of have to go together, the data collection, the data processing, and then kind of what are the app interventions. So this is work that will be interesting to see, do we find the same signals in India, in Bangalore, and Bhopal? But it kind of shows you it all kind of works together. And a lot of this stuff, again, has been more of a research part I've showed you. And it doesn't make much sense if we're not looking at the clinical utility of it in some ways. And I'll kind of go over how we keep a lot of this grounded, how we kind of move from the data to the theory to the applications. And one thing that we quickly learned in doing this research was that a lot of patients may have a smartphone, but may not know how to use them towards health. So we made this new program called DOORS, Digital Opportunities for Outcomes in Recovery Services. This is a screenshot from our new website, but really it's a set of 8 lessons. We kind of took them to clubhouses, sort of equivalent like you guys have Fountain House in New York, and we would take them to our Massachusetts clubhouses. And what we would do is we would kind of have a group and talk about in session one, what is a smartphone? How can we use it? Session two, how can we use our smartphone to stay healthy? How can you just look at your step count in your smartphone? And you can see we'd kind of build up people's kind of digital health literacy towards mental health through these 8 sessions. So we have the manual online, and you can kind of access all our lessons. We have the PowerPoints. We should have a new website that kind of is more, we realize if COVID, we have to move towards online groups. So we're building kind of a whole new interface how to do it. You can see a pretty good idea of how we kind of teach people who, again, it could be you don't even know how to have a smartphone to you have one, but you want to learn how to use it towards health, how to use their phone. And overall, we found that patients were very excited to do this. And they kind of left these groups going, wow, I kind of do want to learn about kind of more things in digital health. So this is kind of just digital health 101 for anyone who kind of wants to catch up and learn with what they have. We also found that I'm going to talk about kind of how we put this together in what we call a digital clinic. But if we're using these apps, we're bringing this passive data into clinical visits, we're customizing what sensors we want, we're changing the surveys. That can take a little bit of time, and clinical visits are always shorter than we want. And sometimes when you're installing an app, people forgot their iTunes password, they need to kind of customize different things on their phone. They need to free up memory. It's not really practical to force all that into the clinical visit. So we have a new role called the digital navigator. And the digital navigator kind of has 3 jobs. And one is to kind of help keep up to date on kind of what apps are out there, what could be useful for a patient. We'll talk about how we do that. One is how can you kind of help technology set up and troubleshooting? How do you get the app on the phone? How do you customize it? So if I'm going to see a patient in my clinic this afternoon, which I will, and I say, hey, I really want to track PHQ-9 and step count, the digital navigator can kind of do that. Almost like if I had made a horrible life decision to become a radiologist, and I were to tell kind of the radiology tech, can you help customize and kind of, can you set up a CT this way? The digital navigator can kind of set up the app this way. And the digital navigator can kind of help preview the data, make sure the quality is good, summarize the data as well. The digital navigator has these 3 roles. We have a small paper in press of kind of what are the skills a digital navigator has to learn to kind of do this. These are kind of 2-hour modules, of course, smartphone skills, basic technology troubleshooting, app evaluation, clinical terminology, and basic engagement. And we envision this as a role that kind of is at a research assistant level. This may be someone's first job in healthcare, and that's why we kind of have things about talking about HIPAA compliance, kind of clinical red flags, warning signs. But we think a digital navigator really is a useful kind of glue to bring this into the clinical setting. So how the idea of a digital clinic works is the clinician, the patient are still going to meet face-to-face via telehealth or video visit to maintain a very strong therapeutic alliance. We think it's very hard to remove the therapeutic alliance and get good clinical outcomes. But we'll also have the app, and we kind of saw we can get different things from green into it. We can run some of our algorithms. We'll really have the digital navigator helping us interpret some of this data, making sure it fits into the customized clinical plan, and kind of being that interface between the digital world and the clinical world in that glue. And in part, I'll go to this slide to say we kind of outlined it recently in a paper in General Hospital Psychiatry. It looks like the last part of the citation didn't perfectly fit, but you can see kind of what we'll do is we'll personalize the surveys for the person, and we'll kind of have a dashboard, we'll review it together what their digital data is. We won't spend a whole session looking at these trends. We'll kind of use that to open the session, review what happened, learn about kind of what happened. And then we'll also kind of set up personal learning goals in the app, personal interventions. The digital navigator will keep track of it. So it's kind of a continuous cycle of how the digital navigator, the app, and the data come together to really to support the clinical visit. But the idea is I think it works through a lot of hyper-personalization for each patient. We're really customizing what we're collecting on the app, what it's bringing in, and what we're kind of asking the patient to do, what exercises, what interventions. And I think it's that hyper-personalization and customization that makes it engaging, that makes it clinically useful. And the digital navigator really makes all of that feasible. So this is kind of one of our Many patients, you can see over time, we've done different surveys. We usually always collect mood, which is PHQ-9, anxiety GAD-7. And it's kind of nice. You can actually see that the patient, there was kind of higher mood, and it's kind of come down even during COVID. We're getting ready for discharge. Anxiety has really kind of come down and been more stable. In different weeks, we wanted to track different things. Sometimes we put thought logs in. The step count part didn't work. This person wasn't always taking 0 steps. But again, we talked to the person. We said, hey, that step count thing doesn't work. Let's ignore it. But on our dashboard, we kind of will look at this, and it's a really nice way to help patients build emotional self-awareness as well. But it really helps us kind of track how our patients are doing pretty well. And again, you can just see up here, we had a high anxiety survey. It really was customized when the patient was having panic attacks, what was going on in the moment. So, but we always get PHQ-9 and GAD-7. It's just it's a nice way to do it. And it's funny, in research studies, adherence is generally not great with digital technology. When it's part of people's clinical care, people are pretty happy to engage because they know that clinically, I'm going to look at it, it's part of their decision-making and share their decision-making. So to kind of switch gears, I've shown you a lot on kind of what the research is, what digital phenotyping can do, what these sensors could offer us, how we kind of are using it already in our own clinic of a digital navigator and kind of offering patients training to make sure everyone can kind of partake. There are a lot of apps out there today. I think a lot of our patients, whether they tell us or not, are probably using apps. It's kind of, I think, like when Google first came out, no one to tell their primary care. I Googled my symptoms and I think I have cancer. And so I think a lot of our patients may have tried these apps, maybe using it, but they're a little bit embarrassed to tell us. There's a lot of them. My favorite analogy is kind of the cargo ship containers in a port. They come, they go. We don't have time to look inside them. We just kind of try to guesstimate what's out there. There's just so many of them. And what's really amazing is there's really not much guidance on what these apps are. Usually the FDA kind of increases standards and regulation of time. We are a field that has the distinction of having less regulation for digital mental health technology. See, this is April 2020. So basically the FDA kind of put out a special notice in April saying, there's a lot of stuff in the digital mental health space, from computer programs to apps to wearables. We're really not going to, we're decreasing our regulatory efforts. And again, you usually hear about we're increasing our efforts, we're going to ramp it up. And the FDA said, you know, if something's really bad, we're here, we're going to look at it, but we really can't keep track of all of this right now. And again, you guys can read it too, but again, it tells you when the FDA is saying less oversight, that's impressive. And I think in the lack, it's not that they were regulating this too much before afterwards, but the paper kind of on the right, that figure is actually now like 5 years old, really. It's from really a 2015 research. But the point being, a lot of people look at kind of the star ratings and say, well, it's a 5-star app, it must be good. We've known for like half a decade, star ratings tell you nothing about an app. It's a popularity metric, just like we know that popularity metrics don't tell you who's going to be a good or bad physician. It's the same thing with star ratings. But again, people still rely on them because they're easy. And if you think about it,
John, wouldn't the FDA's purview be invoked when there was the claim by the app or whatever the product was for insurance reimbursement?
exactly. So a lot of these things don't yet go for insurance reimbursement. It's kind of
the recreational.
Exactly. So they try to do, there's a lot of different business models. There's a lot of kind of selling to private, there's a lot of selling to employers right now. There's a lot of direct to consumer. There is some trying to get insurance to just cover it as a benefit regardless of what it is. And there are some people trying to get FDA approval to argue that it should be reimbursed. So the reimbursement space is pretty messy, but definitely very active on how people get it reimbursed. But a lot of ways that apps avoid this is they say, well, in the fine print, they'll say, well, we're just a wellness device. We're really not claimed to be a medical device. We're kind of like vitamin C. We're in the supplement category. We don't even need to fall into kind of this whole FDA regulation thing. And I
Well,
think that's
one would think this would fall somewhere between the FDA and the FTC. And a good example might be 23andMe, which was recreational genetics, but the FDA did, I guess, exercise some oversight.
exactly. And I'll actually show you guys. So the FTC will come into our story very shortly. So you're exactly right. And it's a little bit messy on where the FDA and FTC kind of pick up and join. But I think the problem is in this lack of kind of clear oversight and clear guidance. People have kind of tried to look at they'll Google top apps for bipolar, or there'll be these websites that kind of say, here's our rating of apps, and they kind of have a score. They'll say this app is a 6.73 out of 10. And you just sit there and go, that doesn't make sense because we don't have medications or therapies. We don't say Prozac is this medicine or CBT is this. The content, of course, each kind of time we give a clinical recommendation, it depends on the context and the person at hand. Sometimes the same therapy will work well in the same person at different times. And the biggest difference between an app and a therapy or medication is these apps are always updating. If you look at your own phone and see how many apps have updated in the last week, it's really hard to say what's the best app because they're going to always be changing. So again, this is the same thing of just we really have to be careful of kind of what are these static lists and harms. And this was an interesting review paper from last year. It looked at 3 of these websites that claim to kind of say what are static ratings of best mental health apps. You can see that these 3 websites couldn't even agree. And what they do to kind of, they give these scores. And what's interesting is, I made this up, they'll say ease of use is worth so many points, aesthetics is worth so many points, but the question is of ease of use to who, and why is it worth that many points in the first place? So it really doesn't make sense when you think about it, of how to even make these scoring systems. And what gets worse is you look at this is from the paper days since last updated. So mindtools.io was updated 714 days on average, CyberGuide almost 600 days, and Orca 109 days. So these two, you go, oh my gosh, I'm giving a patient recommendations from something that's almost 2 years old based on an evaluation scheme that doesn't really make sense. So I think it really doesn't, we just have to be careful if we're using external tools and kind of not.
Who are these ratings being performed by?
So each of them has their own different system that they claim works. And again, you can kind of see here, just they're all different. That's the problem.
Well, I don't want to derail you, but it's sort of like Moody's in the 2008 subprime mortgage meltdown. And is Consumer Reports or any so-called impartial, short of the FDA and FTC, are there any impartial agencies that are trying to do this evaluation?
So kind of, which again, so what we've done with the American Psychiatric Association, we've built what we call a mental health app framework, or it's an app evaluation framework. And I'll go into details. And the idea is saying you have to make the decision. If you're the clinician working with a patient, it's your patient, you know them, it's your decision. But we can give you some resources and a process of how to make this decision. And really it starts with kind of risk benefit, ease of use, tolerability, and then kind of this, I'll get into kind of what I mean by interoperability. But so what we did to kind of make this process is we looked at 45 different app evaluation frameworks from different countries, and we basically took about 604 unique questions. And we kind of graphed what are all these app evaluation frameworks doing? And you can see most were talking about short-term usability. Is it easy to use and is a credible developer? And there really were less questions about privacy and security. There were kind of less questions about the therapeutic relationships, kind of ability to send data to EHR. So we took all these questions and we kind of mapped them onto this kind of hierarchy or pyramid. This is kind of, again, risk-benefit ratio, do no harm, tolerability, can we use it? Is it going to get back to the clinical visit? And this actually is on the APA website. I say Google it because that website is hard, but if you type evaluating apps into Google, and gets any apps, it actually brings up the model that we built. And it's called the app evaluation model because we didn't get Dr. Keshavan's help. And so we didn't have a good name for it. But we actually published it in Lancet Digital Health, of kind of model of what to look for in privacy, what to look for in evidence, what to look for in ease of use, what to look for in data integration. So it's a pretty well adopted model. If you actually look at what the NYC Well website does, they actually have app recommendations. You can see that the questions emerge from frameworks by the AMA and the APA to ensure best practices. So NYC Well actually took this framework, and again, here's these same things: security, evidence, usability, data sharing. So you're kind of seeing these same four principles we've defined in kind of this way to think about it, have got some decent uptake. And we actually presented this to the FTC, I guess it was last week on 7/21, because the FTC says this is an interesting way to kind of present apps to people. And I'll kind of show you how we turned this into a website. So right now, what you see here and what you see on the APA website is a little bit theoretical. It gives you questions to guide yourself through. It gives you videos to think about it. But I'm going to take you through the four main levels to understand why we kind of built the four levels, what's the evidence, then show you kind of how we operationalize this into a database that we kind of presented to the FTC because they thought this was an interesting way. So the first layer is kind of privacy. And really, I think this statement still holds, this is from 2017, the needed innovation in digital health and smartphone apps for mental health really is transparency and trust. And that's kind of the foundation that we need for all health. And it's unclear if we have that. Last year, what we did, we took the top 10 apps from just a common search for smoking and depression, and we read the privacy policies. It was really boring. And we kind of coded the privacy policies. What does the app say it will share? What does the app say it will protect? What does the app say you keep? And with collaborators in Australia, Kit Huckfield and Mark Larson, we kind of did a man-in-the-middle attack. We kind of hacked the app and saw, is the app really doing what it promises? Is it really keeping that data? And what you can see, as I won't go into details, a lot of apps were sending data to Facebook Analytics about telling you. So even if you thought the app was protecting your information, something was being sent to Facebook Analytics. And some stuff was being sent to Google Analytics, Google Advertising as well. So it's a little bit, we're still not in a great ecosystem where these privacy policies aren't really guaranteeing you complete protection. What's also tricky is in talking to a lot of patients and clinicians, a lot of these apps have a medical look and feel. They'll make medical claims, but the privacy policies say, no, 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 we're not a medical app. So things like HIPAA, all the data protections you expect as a reasonable consumer don't apply. It's really a wellness app, and you have to abide by whatever we say in a privacy policy. In a technical legal sense, these apps are all kind of should probably be more regulated because if a reasonable consumer thinks you're a medical device, you probably are bound by that anyway. You can't kind of abnegate your responsibility in a privacy policy. But that's kind of what the standard has become right now. So this was kind of the result of the research last year. The Washington Post covered it, and that's how we got connected to FTC. The FTC said that's a little bit of consumer deception. If you think it's kind of not sharing your data, and it really is, that's not great. And this still happens today. This is an article from March of this year, where again, when people try to do security research on kind of some of these popular platforms, this just says within hours, this person was kind of sent a legal letter saying you're defaming us for talking about privacy concerns. This is from February of this year, an article kind of looking at one of these online kind of more app-based therapies saying sensitive information does end up being shared. All the central goal of better tracking user experience, perhaps giving social media companies an easy way to see who's feeling depressed. So this is still an issue that is active with us. And so that's kind of why we really need to dive into what the privacy is. The second issue is a lot of these apps are making evidence-based claims. And really, the evidence is still evolving. I think we all know there's a couple apps that have done really great research we're excited by, but in general, the percent that are evidence-based is not high. Some just still lack a privacy policy. A lot of them are kind of becoming freemium that you kind of have to pay for. Not that many are kind of using classic behavior change techniques. And there's a lot of review papers out there. Where it gets back to, I think it's tricky to be a patient and clinician in this space is, sorry, it's a little blurry. If you look at the App Store descriptions, a lot of apps, like 64%, are making claims about this app kind of has evidence or it's useful or kind of making these clinical statements. But when we kind of went to track back, is that evidence actually there is about 2.7% kind of actually had real evidence from that study. And the reason it goes from like 64% to 2.7% is a lot of apps say, well, we're based on CBT. And CBT is evidence-based. So gosh darn it, if CBT is evidence-based and our app was inspired by it, we're an evidence-based app. And of course, that's not quite true, but you can see it's really hard to know what there is. Sometimes too, I think there's kind of, not by anyone trying to cause harm, but we just want to eyeball what these apps, are they doing what they claim? There was a recent paper that came out from a different group that said some people are probably making apps with good intentions, but not keeping them up to date. And sometimes non-existent or inaccurate suicide crisis hotlines were kind of being on these apps publicly accessible. So that's pretty concerning if kind of even the most basic information of how to contact kind of crisis information is not accurate on these apps. So even if we think the peer-reviewed evidence isn't there, it may be worth you eyeballing the app to make sure basic things look like they're actually there, and that even if the app claims it does CBT, does it even meet your test? Because again, there may not be that many with research evidence. So, but I think it still may make sense that we look at these things. And again, there's a lot more to talk about risk and evidence. For sake of time, I won't. I'll talk about ease of use is a huge thing. This can also be engagement. This was a really interesting paper that came on JMIR, and they kind of looked at consumer data of how long are people using apps for. And they took popular mental health apps with thousands of downloads. And you can kind of see retention rates after 2 weeks is about 5% of people are still using the app. And that tells you if you just give someone an app, even if you think it's private and you think it's evidence-based, and you say, here it is, go for it, you're going to lose 95% of people at 2 weeks. And this is a figure from the same paper. And what's interesting, you see the peer support apps are doing a little bit better. They're still having engagement issues, but you can see gray is peer support. It wasn't many in the study, but there's an interesting trend that peer support seems to at least be holding out a little bit better and getting to 10% engagement. But I think really thinking about, are these apps engaging? Can people stay using them is very important. Just because an app, it's not always going to work. I'll skip this for sake of time. We looked at the most popular app for schizophrenia. We really found the exact same trend across America and the country. There really are only about 50 people actively using it, which is a lot of money and effort to support 50 people. It's not a mental health specific thing. This was a study that Apple actually did in asthma a couple of years ago. It was published in Nature Biotech in 2017. You kind of see the same decay curve and issues. So it's not that people say, well, this is mental health, this is an engagement thing, this is negative symptoms, this really is a broader issue of digital health in general, kind of thinking about this engagement, and really shows the need for kind of human interaction or clinical interaction as well. It can be countered. You can probably see behind me, we like Post-its in our group. We always are ordering new Post-its. If you guys have cheap Post-it solutions, let us know. But you can really do a lot of cool design work with patients around these things. You can really kind of design things to be engaging. You can think of kind of digital clinics, digital navigators, but you really have to put a lot of effort kind of into this, into the design. The fourth layer in this kind of APA model, this pyramid, is really thinking about kind of clinical engagement, data interoperability. On the left, I just showed kind of data silos. You don't want all the app data on medication adherence going to one data silo, all the app on CBT going to a different database, all the app on exercise going to a different database, all the DBT diary guards going somewhere else. That just ends up fragmenting care. You really want the app data to be sparking a clinical conversation, supporting relationships, improving the therapeutic alliance. And we don't really know too much about how apps impact the therapeutic alliance, how we can kind of use them to work on common goals, bonds, and tasks, which are the kind of elements, at least of the working alliance inventory. But I think this is an important part that's kind of often overlooked. So putting it all together, again, these steps kind of intuitively make sense. We want to make sure the risk-benefit ratio makes sense in 1 and 2. If it does, can people actually tolerate it? Can they use it? And then is the data going to kind of be used in a way that benefits care? We're not just tracking steps for the sake of tracking steps. So we're fortunate that the APA has kind of endorsed it. We've written about this model, and here's more details on it. But we realize it's a lot of questions to ask. You don't have to answer all the questions, but it still is, it can be a long thought exercise to go through. So what we've done the last.
John, let me just, because we got a bunch of questions that are coming in. So I do want to have a little bit of time to ask you those. So if you could just try and wrap up.
Yeah, we'll wrap up in 2 minutes. So what we basically did is we took all of those questions here and we kind of flattened them into a database. And you can log on to this database now. It's apps.digitalpsych.org. And the idea is that we want to basically let people search for features of an app that they want. And again, we don't know what ease of use means. We saw that prior slide. That varies by people, but we can go from easy to use to engagement style. So do you want an app that has peer support and text messaging? Do you want an app that has video and gamification? The idea of the database is it has a lot of questions. You don't have to answer all of them, but you can query the database to figure out, show me an app with all the privacy features and text messages and engagement features. Show me an app that has no privacy because I don't care about it. So really it's kind of a way to actually kind of make these kind of theoretical models very actionable on this database. So you can look at it today. I think we have about over 200 apps altogether. And I'll end with that. So thank you. Sorry, it was a lot of content to cover.
No, that was wonderful. And I remember, I'm dating myself here, years ago when I was following the pop rock music scene, there was an article in Rolling Stone magazine that was titled, I've seen the future of rock and roll, and its name is Bruce Springsteen. And I can say, to paraphrase, I think we're seeing the future of psychiatry and mental health care, and its name is virtual and digital technology. So thanks for giving us that kind of overview. Let me try and give you kind of a rapid speed round of questions. Have you considered, if you get permission, following credit card spending as a measure of clinical course and relapse?
So we haven't. There are papers I can send people where people have looked at credit card spending as kind of a proxy for different types of measures. People get there. I mean, I can share. That's very sensitive information. Just like if you use GPS, you really have to explain to people what you do.
Well, let me ask you, do you think it would be an informative measure if you could get access?
I think it certainly would be if you could get access, right? If you could also learn you could learn even just a lot about diet, right, too, and about kind of, without people logging their food, you could see are they eating kind of more fast food or not. So yes, if you could get it in an ethical way.
Are you familiar with the National Health Service program meant to predict substance abuse relapse?
No, but there's many efforts.
It's being done with a U.S. company called Predict Care.
And it's also hard because there's so, again, once you have data, it's rarely, you can collect data fairly easy, as I showed you. I mean, if our group could make an app and share it, most groups can make an app, but yes, I'm not familiar with that one, but there's a lot of prediction efforts out there.
Well, I mean, the only significance there is that the NHS has somehow found that to be the one to at least use. So here's a research question. Does dropout rate differ among psychotic disorders and mood disorders? In other words, are patients with psychotic disorders less amenable to participation in studies where they're being tracked?
So generally the answer is no from what we've seen. It really depends on how much information you give back to people and is it meaningful to them. But we really haven't had people that have, I mean, perhaps those people don't come to our studies, but we haven't had people go, I'm paranoid, I'm using an app. And we actually did a study of NAMI 5 years ago. And we actually asked this question, this NAMI survey study, does technology make you paranoid? And it was the same rate as the general population of someone just kind of saying, I think the CIA is spying on me with my phone versus kind of, so it actually was no different than, and well, I'm not going to comment on what the CIA is doing or not doing. I'm sure but yeah, we'll leave it at that.
So your utilization of these apps and this technology generates massive amounts of terabytes of data, I'm sure. Have you applied AI at all to the analysis?
So we have applied AI to it. In part, though, as you can see, first, there's a lot of missingness, and one has to kind of consider how you treat the missingness. one also then has to kind of consider when are those proxies and signals valid to apply AI. So there's kind of two pre-steps, but we have kind of built different AI kind of models. In general, anomaly detection, when I showed for relapse prediction, technically is kind of an AI model. It's kind of looking for those patterns. It's more than just outlier detection, what I framed it out to be. But there have been a lot of AI efforts towards this. I think replication is becoming the new gold standard because when you have that much data and such, you're always going to find a pattern the first time, right? And the real question is, can you find on a different data set with a different team that same pattern? I think that's kind of the new hot area is, can it replicate?
Um, what's the informed consent process for using these apps with patients? Are they different than informed consent for other procedures or sharing of information?
No, generally the same. We have a table, we go over what each sensor is, we have a checklist to show people is it always on, is it always off? We show people how they can opt out of the study by deleting the app, how they can turn off different sensors in the phone. So generally it's the same.
Um, is it, has anybody done, or are we moving towards a situation where part of mental health care will be, you have your media literacy training or your digital literacy training, but that will equip people with the kind of minimum requisite platforms?
It may be, and I think we've been kind of looking into building a new 8-session protocol. Could we kind of have a 8-session therapy protocol where we kind of use the technology to really hopefully get to a more accurate diagnosis? And we use the technology to expose you to a lot of types of therapy, and then we equip you with a digital toolkit. And you go into the world with your digital toolkit. So one number.
Do you provide them with the hardware?
So we don't provide people the hardware just because we help people. I think as Project Lifeline, we can help people get phones from the FCC if they don't have them. But generally, we found, again, we saw from those numbers, there are 20% of people that don't have the hardware. But generally, increasingly, people have the phones. They may not have fancy phones. They may not have all the bells and whistles. But to do the basic stuff, we found increasingly people do have the hardware. So we try not to supply people the hardware. We teach people how to use Wi-Fi so they don't have to use their limited data plans very quickly. That's one of our first lessons in the digital training is how to connect to Wi-Fi when you can.
So let me be a little provocative here. When you were talking about the ratings of the apps and how valid they are, in the absence of the FTC or the FDA, and judging by what you see in the media, whether it's Prevagen or whether it's these amazing diets that people can go on to lose 50 pounds in a week, there's really no truth in advertising standards anymore. And so why should there be in the app world? If these ratings are based on some self-appointed entity or worse, a organization that has a financial interest in it, how can they be relied on? So it's not surprising at all that you're finding huge variation in those. But isn't the real kind of gold standard or holy grail of legitimacy and efficacy their validation? So on one hand, you're developing things that are acquiring data in an exploratory fashion. On the other hand, when they're ready for prime time, one would like to think that they're have validated in terms of evidence showing how they have either contributed to care in the way of diagnosis, prognosis, treatment, adherence, treatment efficacy, outcomes, etc.
No, I agree. And I think we're still rather far away from the good validation studies. Like one of the first apps that the FDA approved for substance abuse, the pivotal validation study was actually done on desktop computers. And the FDA said, well, it works well on a desktop computer, so it will give the approval for kind of mobile version as well. And I think all of us know that a smartphone is very different than a desktop computer, and even the structure of going to a computer center is some type of intervention. So I think in some ways, because we just don't have these very good pivotal studies right now, or we have a lot of pilot studies, we do need something to help us sort through what's out there. And because there are direct to consumer, I mean, last time I was in New York, there was Michael Phelps on a billboard telling me I should like use an app for mental health. So
Right.
like if patients are being exposed to that, it makes sense we should be kind of equipped to at least offer guidance and conversation and say, well, let's talk about how is it going to work for you? What are there privacy concerns? Is there evidence? Are you going to engage with it? So we don't have to be experts in every app, but I think we do as a field have to be able to kind of give patients our thoughts in a logical manner. I think the database we built is kind of a way to at least say, well, you really want apps, you value privacy, and you agree there's not much evidence, so let's not search for those features, but you really, engagement's hard and you really do better on video. What are the really private apps of video? Let's see what's out there, because I think we need some tool to kind of guide it. We also need clinicians to be aware of this because we need as a field to be steering what matters and what we're using. I don't think we want third parties to say, well, here's all the tools they were kind of developed about our input. If we don't kind of have ourselves the digital literacy to kind of know what's being forced on patients, we're not going to have as big a stake when this, as you said, this kind of future rapidly comes to us.
So just reminding the 250 people who are still with us, if you have questions, send them to me via email and we'll ask John about those. But here's another one. Is there any efforts or intent to link these to EHRs?
So there's a standard called Smart on Fire, FHIR. So the federal government has finally endorsed a standard of how this data can be linked to EHRs. When the part of the 21st Century Cures Act comes into effect in November, the interoperability rule, there'll be less data blocking that's allowed by EHRs in theory. And because we have a standard, it should be much more possible for apps to send data to EHRs. That said, because of kind of a lot of data blocking on the EHR side and the standard wasn't finalized, we really had very few apps or companies doing it. It's still a little bit expensive, but it's definitely coming and necessary and kind of fits into that top of that pyramid model because that's like the data integration is very tight. It's easy to kind of bring it into the session if we can access data through EHR. But right now it's usually rare.
Here's another question. How does the development of digital tools in mental health care and psychiatry compare to other disciplines in medicine?
So I think actually our field has gone further and faster in other fields. In part, it goes back to those initial slides about active data, passive data, and interventions. We can do a lot of our history. We can't replace it, but we can do a lot of history gathering stage through an app, through sensors and surveys. We can have the app, in theory, also kind of offer some interventions as well. So because we can theoretically do so much through a screen, and the barriers to entry are so low because we don't need a glucose measurement, we don't need an external EKG. I think if anything, we've had a lot of efforts. And again, I think because the barriers to entry are so low, it's not a good thing that in some ways we've had a lot of kind of noise, but I think there's actually more research, there's more evidence, there's more work happening, I'd say in mental health than in other fields because of that.
So even though you've been just a center of innovation and productivity in this and within academia, the majority of the effort in product development is going on in the private sector. Do you feel the private sector is, how do you see the engagement between academia and the private sector, given that the motivations and are not necessarily wholly congruent?
Yeah, I mean, I think that there will have to be collaborations between it. I think that what can be tricky is we all know things in mental health are complex and take time, and sometimes the private sector isn't given enough time to develop things or to iterate. Sometimes they have a really huge shot, but they kind of have one or two shots and then kind of funding gets difficult. So I think that the private sector, I think certainly their investors need to be a little bit more forgiving or kind of think about ways to really make this work in an iterative fashion. And I think from academics, there's pilotitis. There's a lot of digital tools that have been developed and kind of disappeared and scrapped. And I think in part that's why we've been very happy to give away and share our tool with other groups, because we said, look, it would be horrible to build something and it just kind of disappears. It's better to let other groups kind of work of it and take it up. But I think that collaboration between industry and academia is still evolving in this space. But that said, the whole space is, again, very, very new in what we're learning. I think before, engagement really wasn't an issue 2 years ago. People thought it was an app. We give people an app, they're going to use it all the time forever. And so I think we're still, I think we've defined what all the problems are now. But I think, so I think we'll see more efforts, but it's certainly, we haven't seen perfect collaborations yet.
So Ravi Shah has a couple of questions. There's no top 10 list for drugs, but do we have a list of technologies that are tried and true that would be recommended to clinicians now for specific indications?
So again, not for apps. And again, I would say that's why we kind of built the database to kind of, or the app evaluation model is to really get us a way of thinking for that. Because I think we don't really, because these things are changing so much, they're not stable, the evidence isn't there, that we really have to think about how we customize them to our patient at hand.
Okay, so to tie this to the topic of the moment, COVID, so the stage of development for these types of digital applications is sort of like the testing methodology. We're still trying to develop it and refine it.
Exactly. Yeah, we're getting, some of them work better than others, but we haven't really seen nice validation in different samples or it. And we do want to get there because these apps can offer asynchronous telehealth, right? If video visits or synchronous telehealth, we really could expand access to care with these. I think that's the potential if it works well. And I think that's what makes it such an engaging tool if we can do that, is they can certainly augment and supplement telehealth. And in even our digital clinic model that we've used, we found it's a very nice combination, the apps to kind of really extend that care quickly.
A second question from Ravi. How do you see technology-enabled mental health services fitting into this, like from Talkspace and Lyra Health? How can patients know that which of these services are high quality given they're enabled by technology and provided by licensed clinicians?
So it's hard to know if any of these services are actually different, again, of what they're doing, that they all have a technology platform and they connect you to someone. But it's pretty common in year 2020 to kind of use technology, especially in COVID, to connect with someone. So I think the bigger question is like, what are they offering? What innovation are they offering that's different? There's a lot of telehealth video visit services, but it was just letting you connect with a clinician, and sometimes it's not even a licensed clinician. That's important.
It's not really innovative. It's like a therapist in a box, but you don't know what the quality control is.
I mean, I would argue that, again, each hospital, my hospital, Beth Israel, could make that. You guys could make that. It's not, the barriers to entry are low there. So I think we're going to see a lot of people offering it, but it's not really innovative to say we offer care through a video platform in year 2020 in the US.
Well, last question is in terms of the regulatory environment. So both with telehealth as well as with the use of digital technology for passive and active monitoring and interaction, apart from the HIPAA, apart from the reimbursement, what about licensure? So if you have somebody that's traveling around using this in other states, has there been any work to try and clarify that?
So apart from kind of the emergency declarations now, not yet. It's still kind of one question of, are you practicing medicine across state lines once kind of these COVID emergency waivers go away? The FDA does have a program called pre-certification. It's in the pilot phase of a new way they would regulate apps and technology. It's a little bit political because Elizabeth Warren has written at least 2 public letters criticizing it and saying she doesn't like the pre-cert model, she feels. And so certainly, I think that we're not going to see much movement on this FDA's pre-cert effort. But I think it's worth Googling and looking up what is FDA pre-cert, because in their defense, they can't regulate every single app and every time an app updates. That's trying to count grains of sand on a beach. So there are kind of new potential models on the horizon, but they're political.
Yeah, well, there has to be some more broad, sort of general comprehensive legislation, because, for example, our hospital, since everybody has adopted telehealth very effectively in the aftermath, it removes some of the geographic boundaries to scope of care. So our hospital's encouraging us to apply for medical licenses in New Jersey or in Connecticut, and that's just not a very efficient way to go about expanding the scope of practice. So with the technological elements of care, the problem would be just multiplied.
Yes, it's that simple.
Well, listen, John, we could go on indefinitely, but this is fantastic. It was really a very helpful, overview of this space, which is going to be increasingly important in healthcare and mental health care. And we really thank you for taking the time to be with us today virtually. And we'll look forward to having you back, hopefully even in person, as soon as it's safe to go back in the water.
I hope so too. Thank you guys, and good luck carrying on. Bye.
Okay, you too. And everybody, so we'll be in touch with regard to the faculty meeting, and otherwise you've got August off for this time frame. And remember, we've got your back. Stay COVID safe. Be well.